highlight evidence gaps in the African context and discuss the need for African-led research that is grounded in local realities to promote the generation of context-specific data for evidence-based decision-making. Then another objective for today is to critically examine the challenges facing cancer research in Africa and propose actionable solutions for strengthening and connecting cancer research. The last objective for today is to explore strategies for strengthening and connecting cancer research institutions and networks across the continent. So the agenda we mentioned, I think, especially in regards to this session, I am Dr. Sambunya, I'm an advocacy relations consultant working with various organizations, but also double up as the Africa Cancer Research and Control ECHO Vice Chair of the Steering Committee. We have Professor Ntokozo Ndlovu as well, who is the chair of the steering committee with us, and also Mishka Koli and Phoebe Ongadi and the Kenco team also from the hub in this session. And we will have two presentations, and I think we had mentioned that Dr. Simon Manga, who is the Assistant Professor of Reproductive Health, Department of Obstetrics and Gynecology, University of Alabama, present first before Professor Will Ngwa, Founding Director, Global Health Catalyst, Program Manager, U.S. Advanced Research Projects Agency for Health, also presenting his didactic presentation. And then we'll have a section where we'll have a discussion point where we can just have some conversation about this particular topic and hopefully have a way forward on the same. And then in the end, we'll have the Executive Director of the Hub, Africa Cancer ECHO, from KENCO, which is the Kenya Network of Cancer Organizations, Ms. Phoebe Ongadi, do her final announcements. Right, so this is myself. I don't need to explain myself here, but ideally, I work very closely with a number of organizations, but primarily for the blood disorder community, but I also have a very strong interest when it comes to cancers in sub-Saharan Africa, having managed programs in Ampath in Eldoret, Western Kenya, for both blood disorders and cancers. So we'll present, we will also have Prof. Will Ngwa, who is the founding director of the Global Health Catalyst, started at Harvard and extended to Johns Hopkins and other world-leading institutions. He leads development of transformative healthcare programs at the United States Advanced Research Projects Agency for Health, and he's also the co-founder of the Global Oncology University, training tens of thousands of oncology health professionals and supporting the establishment of comprehensive care cancer centers of excellence in different low and middle income countries. His academic service includes serving as ICTU Distinguished Professor of Public Health, as Rutgers Presidential Fellow, and Professor of Global Health and Radiation Oncology as guest professor at the University of Heidelberg, Germany, and visiting professor at the University of Pennsylvania. So he's also a co-chair of the Africa Oxford Harvard Hopkins Clinical Trials Network, and he has served as the chair of the Lancet Oncology Commission for Sub-Saharan Africa, and he'll be having a presentation on the same about the Lancet Oncology Commission. Prof. Ngwa has received over 45 prestigious awards, honors at Harvard, Johns Hopkins International Professional Societies, and other organizations for his leading efforts in global health service and cancer research, including the United States of America President's Lifetime Achievement Award. So we definitely commend him for that. He completed his undergraduate studies at the University of Bio in Cameroon, graduate studies in physics at the University of Leipzig, Germany, and completed his clinical training in radiation oncology at the MD Anderson Cancer Center and Harvard Medical School, United States. So thank you very much, Prof. Wilmgwa, you're with us. But as mentioned, we'll have Dr. Simon Manga do his case presentation first before you. So I'll introduce Dr. Simon Manga. He's an assistant professor of reproductive health at the Faculty of Department of Obstetrics and Gynecology at the University of Alabama at Birmingham, USA. His main research interest is in women's reproductive health, including cervical cancer prevention and family planning. He pioneered the Women's Health Program of the Cameroon Baptist Convention Health Services, a large faith-based organization that is leading provider of healthcare in Cameroon after the government. So WHP is a women's reproductive health program that offers cervical cancer screening and prevention, breast cancer screening, family planning, and prevention control of STIs. So thank you so much, Prof. Will and Dr. Simon Manga for joining us today. So I will have an opportunity here to share Dr. Simon Manga's presentation so that we can have it on board. Great. As mentioned, please do introduce yourselves in the chat box if possible. And also, as mentioned, you could have some questions for the presenters today. So, Dr. Manga, just to confirm with you, you can see the screen all projected, and let me know by just mentioning change slide so that I may be able to change slide for you.
Okay, thank you so much, Dr. Punya. Yes, I can see the slides very well. So I am presenting a case study, a clinical trial that is running in Cameroon entitled Misoprostol to optimize prevention of cancer of the cervix. And this is a double-blind randomized controlled trial. It's being funded by the U.S. federal government through the National Cancer Institute. Next slide. Yeah, I have nothing to declare. Next slide. This is the outline of the presentation. There will be a brief introduction. Then we'll talk about two concepts, the concepts of the SCJ and the TZ. And then I'll present some preliminary studies that led to the current clinical trial that we are doing. And then we will now talk on the active study. Next slide. So we are actually conducting a double-blind randomized controlled trial among 420 non-pregnant women in Cameroon who are undergoing cervical cancer screening using the visual inspection with acetic acid. And these are women with type 3 transformation zone of the cervix. Type 3 transformation zone is our keyword. I've underlined it. So that is what the study is all about, type 3 transformation zone. And then these women are randomized to receive either misoprostol or placebo. So we have two groups of women with type 3 transformation zone. One group receive misoprostol as an intervention group, and then the control group receive misoprostol, placebo, sorry. So, but the big question is, what is type 3 transformation zone? So for us to understand this, we have to start by defining what the squamous-columnar junction is. Next slide. So for those who are not familiar with cervical cancer screening, the squamous-columnar junction is a very important key mark, landmark of the cervix that is used for cervical cancer screening. It is always abbreviated as SCJ. So normally the cervix is covered by two types of epithelium, the squamous epithelium and the columnar epithelium. The squamous epithelium, as you can see here, is made up of several layers of cells. It's multiple layers of cell thick, while the columnar epithelium is a single layer of cell. And the SCJ is where the squamous epithelium and the columnar epithelium meet. Okay, next slide. So here we can see some pictures of the SCJ, and clearly you can see the difference between the columnar epithelium and the squamous epithelium. The columnar epithelium is pinkish or is reddish because of the one cell layer nature, while the squamous epithelium is pinkish because of the multiple cell layer nature. So now you can see the SCJ in all of these photos that are here. You can see where there is that junction between the squamous epithelium and the columnar epithelium, which takes the form of a circle, and it is measured in 360 degrees. So this is a very important landmark of the cervix when it comes to cervical cancer screening by visual methods. Next slide. So this leads us to the concept of the transformation zone. So the transformation zone is defined using the SCJ. So here we say area between the original and the new SCJ. I don't want us to go into that concept of new and original SCJ. That is beyond the scope of this presentation. But now, just looking at this photo, the SCJ was once upon a time within the ectocervix. I don't know if you can see my arrow. The SCJ was beyond where it was, and then it starts migrating. So in this case, columnar epithelium were found right at the ectocervix. And then there is a process called squamous metaplasia in which the columnar epithelium is being replaced by squamous epithelium, thereby reducing the SCJ. And so the SCJ keeps migrating over the lifespan of a woman. And at one point in time, we'll find it at the nature of the os, and at another point in time, it will get into the internal canal. So let's see that. So one other point that we should note about the transformation zone is that it is, or we can also say is the area of the cervix that was once covered by columnar epithelium, but is presently being covered by squamous epithelium through the process of squamous metaplasia. And this is the area where over 90% of cervical precancers and cancers originate. So during cervical cancer screening with visual methods or colposcopy, the first intention is to see the entire transformation zone. Because if you fail to see the entire transformation zone, then you might be missing a very important portion of the cervix. Next slide. So the next slide, we'll see the different types of transformation zones. We have three types of transformation zones. We have a type 1 transformation zone where the SCJ is ectocervical. You can see the SCJ 360 degrees at the ectocervix. Type 2 transformation zone. The SCJ is also seen at 360 degrees, but either part or all of the SCJ is at the level of the os. So with type 1 and type 2 transformation zone, the SCJ can be seen at 360 degrees. That's 100%. So in that case, we'll say we can see the entire transformation zone. Once you can see the entire SCJ, then you can see the entire transformation zone. Type 3 transformation zone is when part or all of the SCJ cannot be seen at 360 degrees. So women who have this type of transformation zone, when you do their screening, you cannot see the entire transformation zone cannot be seen. So the woman might have a lesion which is growing in a part of the transformation zone that is beyond view, and that can be a problem. Next slide. So there are challenges with type 3 transformation zone. Again, women develop type 3 transformation zone of the cervix as they age. So find this is more prevalent among postmenopausal women, though we can find it more, we can also find it in younger women. So women with type 3 transformation zone cannot be adequately screened for cervical cancer. So they can easily have a false negative result because part of the transformation zone has gone into the canal. So in this clinical trial, what we are doing is to reduce the type 3 transformation zone. In the Western world, or in the US and Europe, they have what they call endocervical curettage, which they do to sample cells of the endocervical canal of women with type 3 transformation zone. But in Africa and many low and middle income countries, this does not really exist. So we have to explore other methods to address this issue of type 3 transformation zone. Next slide. So we did a case study of two women who had type 3 transformation zone of the cervix, and they were screened negative in one of our hospitals in Cameroon, the Bingo Baptist Hospital. And shortly thereafter, they were diagnosed with invasive cervical cancer. Next slide. So these are the two cases. The first case is a 46 years old gravida 4 para 4 HIV negative woman who screened negative with type 3 transformation zone. And in 10 months, she came back with symptoms of invasive cervical cancer, which implies that she already had invasive cervical cancer at the type of screening, but it was missed because of the type of transformation zone that she had. The second case was a 70 years old gravida 7 para 7 HIV positive woman who had type 3 transformation zone, and she came back with symptoms of invasive cancer 22 months later, which again is likely that she already had some lesions at the time she was screened, but that was missed. Okay, next slide. So then we did now an integrative literature review to find out the effects of misoprostol and estradiol. These are two drugs with cervical modulation effects. We wanted to see how these two drugs can be used to enhance visualization of the transformation zone. Next slide. So this is the conclusions that we got from the integrative review. We saw that both oral estradiol, intravaginal estradiol, and intravaginal misoprostol can be used to convert type 3 transformation zones to type 1 or type 2. And we found out that a single dose of intravaginal misoprostol had similar effects like multi-dose regimens of oral and intravaginal estradiol. And then we also found out that intravaginal misoprostol is more feasible in low and middle income country because of its single dose regimen and the costs. Next slide. So in the next, we did a pilot study to find out the effect of intravaginal misoprostol among women with type 3 transformation zone in Cameroon. And this is what we found in our pilot study. Next slide. So conclusions from our pilot study, we found out that misoprostol was able to convert approximately 50% of type 3 transformation zones to type 1 or type 2. And among 90 of the 107 women with type 3 transformation zone, 84.2% had conversion. But actually, what we did in this study is that we piloted 2 doses of misoprostol, 600 micrograms and 400 micrograms. And we found out that there were more conversion with the 600 microgram compared to 400 micrograms, though there were most reported side effects with 600 micrograms. So next slide. So now this led us to the clinical trial that we are currently doing. And the overarching aim of this clinical trial is to evaluate the efficacy and acceptability to use misoprostol to convert type 3 transformation zone among women in Cameroon who are undergoing VIA. So as I said earlier, this is a double-blind randomized controlled trial of non-pregnant women to have 2 arms, the implementation or the intervention arm of 210 women and the placebo arm of 210 women. That's in the ratio of 1:1. So we give misoprostol come in 200 micrograms. So we use 3 tablets of misoprostol and use 3 tablets of identical placebo that has been both manufactured by the same pharmaceutical company, and they are so identical. So a double-blind randomized control trial. So the nurses who administer the drugs don't know which woman is in which group, and the women receiving the drugs don't know who is in which group, and the researchers don't know. And so that is how it's only the pharmacists that blinded, that did the blinding. So after the insertion of the drug, participants are examined serially at 2 times points, at 2 to 3 hours and at 4 to 6 hours. 2 to 3 hours, if there is conversion of the type 3 transformation zone, then the patient is discharged. If there is no conversion, then the patient is examined again at 4 to 6 hours. Next slide. So our primary aim is to evaluate the efficacy of intravaginal misoprostol on the conversion of type 3 transformation zone. And our sub-aim is to identify the factors that influence time and other factors on the rate of conversion of type 3 transformation zone, while our secondary aim is to assess the patient and providers' satisfaction and acceptability in integrating misoprostol for reducing type 3 transformation zone of the cervix during cervical cancer screening. Next slide. Our inclusion criteria are women aged 25 years and above who have type 3 transformation zone. And we exclude women who are pregnant because, misoprostol is an abortifacient. So the first step is that every woman had a pregnancy test. We also excluded women who have had total abdominal hysterectomy, women with any form of gynecological cancers, and women with active cervicitis. Next slide. So the study is running in 7 sites in Cameroon, 7 clinics of the Cameroon Baptist Health Service. And this is my last slide. Next slide. So this is the end of my presentation. Thanks for listening. Over.
Hey, thank you, Dr. Manga. I think that was just timely. I know it was a bit of a trouble there trying to mute the person who came in, but I think we're good. And it was quite timely that the presentation stopped. So thank you so much for your insights. And I just want to open it up for the floor. If there's any questions, please do raise your hand. And also, if you have any questions, please put them on the chat box as well. We'll be looking forward to have them on board. Yes, so we have Dr. Kudus Lawal. Please, you can introduce yourself and go ahead with the question to Dr. Manga.
Yeah, thank you very much, Dunia. I'm Dr. Kudus Lawal. I'm a member of the steering committee and I'm a gynecologist. And this is very interesting to me, more so because in the low and middle income countries, we do have limitation in managing women who have type 3 transformation zone, especially when you are talking about ablative therapy. And I'm thinking beyond screening, beyond the use of misoprostol to aid screening to do VIA, can we start looking at administering misoprostol for the purpose of transforming type 3 to type 2, type 1 transformation zones so that ablative therapy may be applicable in that situation? I mean, I'm just thinking beyond the finding of this study. Thanks.
Yeah, that's a great point. Thank you so much, Dr. Kudus. I think that's something to be looking at. Our study will surely give us some information, some insight into what you are asking. And I think that could be one of our next steps. Thank you so much for that inspiration.
All right, so thank you very much, Dr. Kudus, for that question. I'm going to try and see if we have any other questions on the chat box. So yes, so there's one from Mishka Koli. So Dr. Manga, congrats on this study in or post the initial study. Were there any side effects reported by study participants?
Yes. Even from our pilot study, we had side effects reported. And we are actively collecting side effects in this present study. So we are going to do a comprehensive report of side effects. But so far, we have not had any. We have had very few cases of major side effects, but not to the extent where any woman was admitted because of side effects. Yeah.
All right, thank you very much. Right. I think most of these comments are just introductions. And there is one from Louis Wong Dang. So thank you, Dr. Manga, for the excellent presentation for participants with no transformation at 4 to 6 hours. What did you or would you do with them? And also, for those with side effects, what were the most severe side effects and how would you handle them?
The side effects of misoprostol are already well known. So we are handling the side effects. This study is still going on. So some of these questions, I cannot answer them at this point. Like what were the most severe side effects? We are still on the study, and it's only at the end that we will be able to answer some of these questions. But for those with severe side effects, we handle them just as how side effects of misoprostol will be handled. Like if a woman is bleeding, we'll administer, we have this drug that we administer. What's the name again? Yeah, we have these drugs that we administer for women who bleed. For women with low abdominal pains, we give antispasmodics. For women with nausea, we give antiemetics. Yeah.
All right, thank you very much, Dr. Manga, for that wonderful answering of the question. So I think Thanks, Dr. Mago, for your presentation as well. Well, I think I see a hand up. Annette, please go ahead, Nakaganda.
Yeah, thank you so much. Good presentation, although because of technology issues, I joined late and I don't know whether I discussed this because one of the challenges is recruitment into the trials in our setting, but also the navigating the regulatory framework. How long did it take you to get the regulatory approval for this study? And are you with the timelines? I know it's going on, but are you able to recruit the required number of participants on this trial?
Yes, thank you so much. The time this is a 5-year study, and we are in the second year. So the first year was just to do most of the paperwork, get IRP approvals from the Cameroon Ministry of Health, from the University of Alabama at Birmingham, and to register the study on ct.gov. And then in the second year, so all that was done in the first year, a lot of paperwork. Then the second year now we started patient recruitment. So we are currently going on with the recruitment. And I think we are within our timeline. So it's not a problem recruiting women. Women are very interested in cervical cancer screening. So we do mass screening and women come for mass screening. Then from there, we select those with type 3 transformation zone and then approach them to consent for the study. Thank you.
Fantastic. Thank you, Dr. Manga and Annette. Just one more question here. Nwamaka Lasebikan, she's wondering, I'm hoping it's a lady, but she's wondering if the presence of side effects does not inadvertently unblind the participants in the study.
Yeah, maybe or maybe not. Because sometimes in some of these studies, we tell the participants, they go through an informed consent. We tell them about the side effects. And sometimes we tell you that these are the side effects. You have low abdominal cramps. I will see a patient where they are still to insert a drug. Maybe they are just with the vaginal speculum. And the patient is like, hey, I'm already having the abdominal cramp. So it may not really unblind the participants because just the fact that you know that there will be side effects. Some people start feeling the side effects even when nothing has been administered, just because of that psychology. So maybe or maybe not. Yeah, we cannot tell at this point until at the end of the study.
All right, thank you very much, Dr. Manga. Do we have any more questions, comments? All right, going once, going twice, and I think it's gone. So if you have any more questions, please do share it on the chat box. We'll be very happy to answer them. And I think Dr. Manga will also be just following the chat box if there's any specific questions that he would like to address, and he may be able to do the same. So I think we can start over to have Prof. Will Ngwa present his didactic presentation. And I think most of us have also been looking forward to have Prof. Will with us, and we found him. So now he's with us on the last session of the year. So it's perfect timing as well. Prof. Will, I know you are with us, and very red where you are. So looking forward to seeing your presentation.
All right. Thanks so much for that introduction. I think, can you hear me? Just make sure.
Absolutely.
Yeah. Okay, fantastic. Yeah, thanks. So yeah, it's really great to be back. Actually, Mishka, I know, and Dr. Alasabek, and they had invited me some time ago, I think when we first launched the Lancet Oncology Commission for Sub-Saharan Africa, and I did present some of this. When I talked to the Lancet editor recently, he was like, it's almost 5 years. We need to start thinking about a follow-up commission to really see where things are currently since this commission was launched. And then obviously the landscape has changed in some ways. So we have I'm really happy to be back. I know we have a number of some of the commissioners who had the Lancet Oncology Commission for Sub-Saharan Africa, including Dr. Simon, who just gave the wonderful talk, case study, Dr. Tokozo, and I know Annette and Dr. Ali. Some of you are already on this call. So this has been it's really nice to be able to be back to just talk about this. The focus will really kind of look at what in light of the focus of this particular session, looking at the research component of this to see what are the strategies that one could consider to keep doing some of the good work that Dr. Simon has done, including in Cameroon. So, so I'm just going to talk a few about some of the highlights, remind people about some of the findings from the commission. This was really done with a lot of, like I mentioned, some of the people on this call, but we had like a 50%, at least 50% of the people who were part of this Lancet Oncology Commission. They were based in Sub-Saharan Africa. At least 50% were women, really important to make sure that we had all the different voices as part of this. And the goal was really to kind of look at what's the landscape of cancer across Sub-Saharan Africa and then make some recommendations. And that kind of fits into the whole theme of this summit, of this webinar, to think about what are some of the recommendations that we can take for, advancing research, including clinical trials, which are really, really important to guide cancer care. So, so the second part of this, I'll just talk about some of the things that have emerged out of this and some of the opportunities here. Sometimes I always like to start with this slide, basically to talk, because the WHO revised this recently, and you guys are aware of this. The challenge of cancer is something that we all wake up every day thinking about. We all know somebody who's dealt with cancer, but we actually know that, currently, it is a pandemic. If you really want to think about how the impact of it, it kills more than COVID did. So this is something that is really important for all of us who are on this call, fighting every day in whatever ways, whatever giving care or doing research. This is really important work. And, it's even more urgent if you take into account the fact that the WHO has recommended that, published this to say, there's going to be a 77% increase, by 2050. So that's really important. And then you think about the access, right? So this is an old map from IAEA, but it still hasn't changed that much to kind of think about the distribution of access to treatments like radiotherapy. You see all the reds are around Africa. The red spots mean that, you likely have no treatment facility like radiotherapy in those countries, so we are very limited compared to the population of the patients there. So we don't only have to find the pandemic, we have to find the cancer crisis, we actually have to look at the disparities as well. So in looking at Sub-Saharan Africa alone, I always like to start with this statement. It's actually done by one of the chairs, Professor David Kerr at Oxford, who basically captured this really well, right? So he said, we have seen too many reports, too many words, too many good intentions, too many families torn apart, and too many excruciatingly painful deaths to see yet more delays in taking action to accelerate cancer control in Sub-Saharan Africa. And I think we all share that sentiment. The report did find out that, there's an explosion in cancer cases in Africa, projections of about 1 million deaths by 2030, which are likely underreported, as we all know. So that was a key highlight of this. And then once you think about this, why is this cancer explosion? We know the reason why this is, this is likely attributed to things like, HIV/AIDS infections, right? So like like Simon gave the talk on cervical cancer. One of the big risk factors of cervical cancer is HIV/AIDS. So that increases that, and that's just one of the type of infections that we can get. The changing population demographics as we now live longer. It used to be that growing up in the village, most people die because of other things, right? Malaria, HIV/AIDS, tuberculosis, all of those things. But now people are actually living longer. As we, live longer, cancer becomes an increased risk because, of course, as you grow older, that's a big risk factor. So the changing population demographics, the behavioral changes, right? So now we like to eat more, adopting Western diets, burgers and stuff like that. They're pretty cool, but those come with a toll, environmental exposures as well. So things like pesticides, as we do more agriculture and fertilizers, we get that exposure. And then the other part is just plain genetics. Like, if we're African, if African women have, breast cancer, for example, earlier than other demographics. And, increasingly we're seeing that for colon cancer as well, which is one of the leading cancers, so genetics is part of that. So this is some of the reasons why there's this cancer crisis, that came out from this Lancet report. And then obviously, I always show this graphic picture, sorry that I show this, but it's sometimes really important to kind of just make that, to shock people, to remember what's really happening. We know that the highest incidence cancers include breast, cervical, prostate, and then colorectal cancer, but it's usually characterized by late disease presentation. And so, there are some estimates that, late disease presentation varies like 30% in South Africa up to 98% in Nigeria. So that's really high. And that's actually one of the things that, as we talk about a global cancer fund in the level of PEPFAR, just downstaging cancer is going to be one of the big things. And that's an area of research where maybe it's implementation research, just behavior, changing behavior, but cultural and creating that access to diagnostic facilities and things like that is going to be really critical. So it's not just, the highest incidence cancers are breast, cervical, but the top killing cancer is actually cervical cancer, which Simon just talked about, a lot of that. Followed by breast cancer. So it really shows that the highest mortality in these cancers, cancer is affecting women. And we know women are the engine of our African societies. I really think that's devastating. So that's something that why this is even more urgent, I think. But there's also the mental health component of that, right? And even we talk about cervical cancer, men are also very important parts of that. We know in the cultures that we live in, sometimes the permission structure, sometimes the the mental health component can be really tough for women with breast and cervical cancer. And so men do have a supporting role even to address that as well. So this picture published in the New York Times, which I always show here, was a patient in East Africa who essentially has cancer. But, in addition to the burden she has to bear, is late presented. Now the culture, the society looks at her, they say she's a witch, she's bewitched. That's why she has this kind of presentation. And so she has to deal with that stigma, has to deal not only with the cancer, but also deal with the fact that the society ostracizes these women. So it's a huge mental health component that they have to deal with. And so as we think about awareness, education, and all of that, these are some of the things that we need to address, even in terms of research questions. What are some ways that we can really reduce this kind of stigma and make people recognize that cancer is something that, one, is not really a death sentence. Sometimes you can say it is for countries where there's no access, but let people talk more openly about it and not, drive that kind of stigma and mental crisis. And talking about it, one of the things we see is that, of course, with Africans, over 2,000 languages, most dialects don't even have a word for cancer, which means you can't even talk about, right? So in some of the villages that I know, you call it something else. It's not, and when they call it like that, it's not even cancer. Maybe it's again ending up being that, you're bewitched. It's because you took your uncle's land or something. There's some explanation. It's not really, and so if you cannot have a word for cancer, you can even begin to treat it. And so no doubt, people present late with that. So there's going to be really important that we have we integrate as part of the cancer control efforts, this kind of awareness creation. I'll talk about one area just want to talk about in this pillar, which is really important for Africa in particular, that was touched about in this commission, which I think is not normally touched about in other commissions or other work in cancer that we've seen as comprehensively or even mentioned, is the idea of traditional and complementary medicine, alternative medical practice. We actually know that over 80% of sub-Saharan African people use some phytomedicine or traditional medicine, right? Phytomedicine, medicinal plants, or some traditional medicine. So it is a healthcare system that we engage with every day. People engage in that healthcare system. And to completely ignore it would be, in fact, people get trapped in that healthcare system in some ways for good or for bad, right? So even it's really important. So the goal here is really important to engage with that healthcare system, respect that. We need to do some research around that, like really work to be able to engage that innovations in that area, including medicinal plants. There may be actually opportunities where we can make some new discoveries in research around that. So then the other part is, in terms of highlights of the commission, prevention and screening. So yeah, poor access to screening and diagnosis. Sometimes, even though we talk about women cervical cancer, women don't want to be screened of cervical cancer if they don't have access to treatment. So it really has to be, those pillars need to be there. And there's an ethical question around that, right? So why do you want to screen somebody where you are saying the cancer days are areas like Chad, Niger, or those countries where you can say you don't have access to treatment, or maybe even Cameroon, where Simon is talking about right now, and they have one cancer center that serves a country of 30 million. That's functional, and sometimes it's often down. So do you really want to get screened? If you don't have access to treatment, that's an ethical question, and that's a really difficult question. So we need to actually address that. Treatment abandonment is very high. Cancer in Kenya, 54%, 46% in Zambia for children. So a lot of contributing factors to this. And so, that is something that, it really needs to be addressed as well, and I think, there are many ways that we can do that. And then finally, just thinking about palliative care. Palliative care is relatively a new discipline. One of the key leaders in this, my friend Christian Tizimira in Rwanda, is really been championing a lot of this, but I think we really need to integrate that into, and I know Dr. Ali as well in Kenya, those are really the leaders here. I think something that, if people have to die, they should at least die with some dignity. But remembering that palliative care is not only end of life, right? So even from the time that you're diagnosed, or, all the cancer care journey needs that palliative care support. And that's particularly important, including for the mental health component of it. So in the US, one of the centers in NIH has actually piloted the whole idea of whole person health. So, and that's a way to integrate maybe the spiritual, the mental, and the physical health. That's really going to be one of the new things that models in global health that people are really kind of focusing on whole person health. I do have a slide here on children because it's really a big deal. 4 out of 5 kids die in sub-Saharan Africa if they're diagnosed with cancer. Compare that in the US, it's like the reverse, 1 out of 5 in the US. And I would say even the 1 out of 5 in the US, cancer is still the leading cause of disease-related death in the US for children. So it's also bad, right? But in Africa, think about the magnitude of that. It's even worse. It's unacceptable. And then lastly, I just want to mention that the economic impact of cancer. So actually, I remember when we launched this Lancet Oncology Commission during the ACON conference with Dr. Amaka in Nigeria, one of the things that, I saw the headline news that actually came out of it was that Nigeria lost $5.6 billion from cancer in 2019, right? So these are some of the numbers that came out of this. Cancer does have an economic impact. And I remember when we talked about this, one of the members from parliament from Nigeria was like, what? So this is something we need to address, right? Yes, because sometimes some people only think about this in terms of the money. They don't, even though the lives are the most important thing. But it's really important to always drive the home that cancer is also an economic issue. So this is really important. So I'm just going to quickly talk about the calls to action. And I don't know, how much time do you still have? 7 minutes? How much time?
You got enough time, yeah.
Okay, super.
Want to see your presentation, yeah.
Okay, super. So I just quickly go through the cause of urgent action that came out of this, and then I'll talk about the one for research more importantly. So one was really precision cancer control. So develop and update national cancer control plans and provide sustained financing to ensure the implementation. So this is something that many people have written about national cancer control plans, and a lot of the people who have developed this, actually have this, gathering dust on some shelves because there's really no sustained financing for them. There's a Lancet commission that's going on right now, in which I'm actually involved in that, and they're looking at the policy, just seeing how, the national cancer control plans, how they're being implemented across Africa. And it's really sad to see that, so this is something that we really kind of a recommendation there that really they should implementation of the national cancer control plans. It's really urgent here. There's some progress, I would say, but it needs to be more to be done. And then action 2 is really improving data acquisition. Like I mentioned, a lot of these numbers we are talking about are actually underreported, they're underestimated. We need to get better data and cancer registration. So investing in that, so that as we think about the investment, cancer control plans, they really need to be driven by data. So that's an important past aspect. Action 3 was designing, healthcare systems that, that promote that equity of access. And this really focuses on universal health access coverage. So patients don't have to, because financing is a big problem. Sometimes, you have to ask whether you have the money. People abandon the treatment because they don't have money, right? So really finding ways that they can provide sustained financing is important. Action 4 is increasing access to care, to cure and improving care. So this really means, the cancer screening, detection, diagnosis, and treatment, making sure that there's that investment into that, so that we can really decrease the time between diagnosis and treatment, no late presentation, increase the percentage of patients who can receive the appropriate treatment as well. So this is something that was also included in this call to action. And then palliative care, like we mentioned, this is really important, especially because, a lot of people are dying with a late diagnosis. So the end-of-life care is really, really important component of palliative care here. Then action 6, I kind of highlight this because building and maintaining the workforce is really critical, including the research workforce, which we're talking about. What are the strategies for increasing research, building research? So, capacity building, even for the research workforce, is really, really critical. And so it was really, and then you see a lot of the disparities. So sometimes when you're a doctor in Nigeria, you go to Kenya or you go to South Africa, the harmonization of education is really important, because somewhere when you go, it's not actually considered. People don't, either they look up or look down on your training. And so being able to harmonize some of that is really going to be important. So building the oncology training programs in each country that can really proportional to the needs of cancer is really, really important, including sometimes even, task shifting, which is one of the recommendations, engaging community-based workers in some of these. Action 7 is really the research piece, which is the focus of this. Talk about how we can strategies for increasing research. So this is one of the calls to action. Number 7, establish national cancer research institutes and committees with great funding streams. Nigeria is a good example that has established NICRAT. It's not necessarily a direct correlation from this commission, but it's a good example of why this is really important. And so really a good recommendation here, strategy to really strengthen research is having, each country establish some kind of national cancer research institute, cancer center, or like NCI in the US, right? Like having that commitment to make, funding. Actually, there was a time when I think it was the Abuja Declaration where people were supposed to commit certain amount of money to health, to research and other things, but countries don't honor that. So this is really a call to have more such investment. And then the other part of it is developing international collaborations, external partnerships in research. And that's really, really critical. We know that actually really strengthens, and advances research innovation better when you have this kind of collaborations. Even though we say international collaborations, doesn't mean necessarily South-North. So collaborating with the US, for example, it actually means, say, Ghana, Nigeria, or Kenya, Uganda. South-South collaborations are also really important in this. And so establishing centers of excellence in research, it's one of the things that we've done with a number of ministers of health as we implement this Lancet Oncology Commission. So many countries now are looking to establish comprehensive cancer centers of excellence, which means it includes research, it includes education, it includes the care, which is really, really exciting to see. All of these 7 recommended actions, people usually say from this commission, the one that people didn't expect, which, is not typical in other Lancet Oncology Commission, says for South America or Asia or that kind of thing, is investing in telehealth. But this is actually, I think, the most critical strategy as you think about advancing research, strengthening research. So using technology. But this is one of the things that is a huge opportunity for Africa to leapfrog, using, because of the mobile phone penetration, even the awareness. We talk about downstaging cancer, things like that. Like, there are a number of studies that are emerging, including in Tanzania, where you can really downstage cancer by just using, access to the mobile phones and digital health. So creating those platforms is one of the ways that calls to action here. And so I'll just highlight one thing that is coming out of this. Is really kind of big as I think about the strategies. Right now, there's a huge investment coming into establishing what we call the Comprehensive Cancer Center in the Cloud. It's an initiative that IBM, kind of started a few years ago. But right now, even the Global Cancer Fund is really looking at, and another funding is coming from the US, really establishing this platform where, it doesn't matter where you are in Africa or the US or anywhere, you can have access to the same quality of care. So when I say care, I mean care, advocacy, research, and education. So CARE, care. So you have that access. So the research piece is really important there for any national cancer control, for any comprehensive cancer center. Obviously, you're doing the research to inform the care and then building the workforce. But advocacy and outreach is really, really critical in engaging with communities. And so having all these 4 core components of care, advocacy, research, and education is one of the key things. So, and the vision is really say, imagine your best cancer center in the world, right? Whatever it is, MD Anderson, Dana-Farber Harvard Cancer Center, your country. Imagine if you can put that cancer center in the cloud. With AI and technology today, you can go down from prevention to diagnosis to treatment to palliative care. And I can tell you there are tools now that people can use that can really advance, especially with AI now. I mentioned for prevention, it's easy for you to send text to women now, and you can educate people on changing their behavior, exercise, nutrition, all of those things. Go and get checked, do breast self-exams. You can really see how you can use that technology, that kind of platform. And then diagnosis, we have Digibox now, and that you can take a picture, there's for the cervix, breast, things like that. You can upload that to the cloud. People can diagnose that from anywhere in the world with AI and tools like that. If you think about treatment, we in radiotherapy, we have, AI tools now that are being implemented in Lagos that are helping doctors to, save 1 hour, long treatment planning and times. These tools are being published every day, so, you can look at that for medical oncology. The question is, do you even need medical oncology in 5 to 10 years, right? Because AI can look at NCCN guidelines, and it can he can basically make the recommendations, and he knows all the data and the updated reports better than you. The doctors don't have to go every time to get updated conferences. It has all of those. So is medical oncology going to be necessary, right? Robotic surgery, all of those things. So you can see how you can implement all of these components in the cloud, right? Then palliative care. There's a recent study in the Lancet that shows that ChatGPT provides better palliative care than humans, right? It supports patients better than in Asia, right? And they used to say AI is not emotional, but if you interacted with AI today, knows that it can be very emotional. People are actually developing friendships with these things and getting addicted. So so integrating all these tools in a platform in an interoperable way, providing access, so empowering patients. So it doesn't matter where you are, you can get a second opinion, you can get your diagnosis, you can get all of those things. It's really part of the future. And I think what that then do, I can tell you this comprehensive cancer center already has core facilities. So which really means that if you're looking for a grant, you want to write a grant proposal, you want to write a paper, you want some data analysis that you're sitting on in your country, you can access this and you can get people help you do that without, you don't have to have all the statistician, you don't have all those things, right? So you can access, these tools regardless of your geography. If you're doing a clinical trial, you usually need somebody to do all the statistical analysis for you and predictions, how many patients should you enroll, all of those things, you can have access to that. So this is really within reach, right? So it sounds futuristic, but actually it's not. And in a few years, I actually believe that this is going to be the kind of transformation that is really going to help. So as I think about this, I think the other one, obviously, that came from the Lancet Oncology Commission is the idea that very critical to research is funding, right? So how can you support all of us on this call, to be able to do research, right? And so there is this, idea that even with this platform, and right now, just this week, there are a number of commitments that are being made, including from diaspora organizations that are looking to drive research and investment. So microgrants, right? Collaborative microgrants. You can have somebody in Kenya collaborate with somebody in Nigeria with the $5,000, $10,000, get some initial data, and then apply for bigger grants. You can even collaborate with institutions in the US as well, right? So those are things that funding is going to be very critical as well. And I'll talk about that in a moment also further. But this picture kind of tells you can have in the future, you can see having a phone with 4 apps in it, or actually 1 app with 4 different application menu items: care, outreach, or advocacy, research, and education. You can access all of this. That really can empower patients and transform the way that we do things. So I'm just, since Dr. Simon talked about clinical trials, I know I was supposed to speak first, but really, so you can make that really great case study. But, one of the key things that you can do through even the comprehensive cancer center in the cloud, or you don't need that, actually really where we should be looking at strategically improving research in Africa is around supporting clinical trials. So I can tell you that every Saturday right now we meet online and we provide quality assurance. We provide support for a multi-country clinical trial that's going on in Africa. It's called hypofractionated radiotherapy, Hypo Africa. It's a consortium that involves partners across Nigeria, South Africa, Tanzania, Uganda, Ethiopia has added, now Cote d'Ivoire and other countries like Ghana, they're joining. So this really is focused on increasing access to care, but actually it's an implementation study because the clinical trial had actually been done in the United States and Europe, but it was never involved African populations. And so just testing to see, is this applicable? And the results are going to be published in the Lancet soon. The results are actually amazing. So it shows that, some of this stuff can also be done in Africa. And the great thing about this is that in doing this clinical trial, the capacity of a lot of these people have been built, and the quality of care has been improved because now they have the infrastructure to actually conduct clinical trials, more clinical trials, but also to care for their patients. And so this is one of the models that, we need to scale. The power of this is that technology can actually help you ensure the quality across different countries. You don't need to travel to those countries. So I just wanted to highlight this. And I think this is a model that, as you think about strengthening strategy, strategically, how do we strengthen research collaborations across Africa? Some of the clinical trials that we're doing, we can use technology to make sure the protocols that are being applied are similar. I just highlight phytomedicine because it was in the Lancet Commission. A lot of people publish a lot of studies across Africa in terms of medicinal plants. So I think this is one way that we really need to kind of support this, and strengthen. And I have been a benefit of participating in some of this research, and I know the power of it because take for example, when you go to the village, you hurt yourself. Like me, growing up in the village, when I'm playing soccer barefooted, you hurt yourself. Then my mom says, "Oh, go back behind, get this grass and squeeze it on your wound." And then the next moment, 1 hour after the wound is here, I'm playing soccer again, right? So what is the power in this kind of medicinal plants? Can we do some more science there? And maybe that can really be a locally relevant solution. If I then come back and say, this is why it helps you, here are the side effects you should consider, you're essentially empowering that indigenous knowledge. And that's something you can then scale, right? The example of malaria and quinine with the pygmies and backs, is well known, right? So I think this is another strategy that we need to enforce as we think about research. It doesn't take a lot of money. It doesn't mean we shouldn't put more money into it, but people can really look at this as a strategy. So this is an example that I've actually done at my lab at Harvard, where we had indigenous knowledge from Cameroon, a plant there that now has been actually being developed with the Smithsonian Institute in Washington. They discovered a plant that had no species before identified. So we're still looking to name the plant, but the plant has really amazing properties that even NASA and the Department of Defense now wants to adopt that, to develop a blood substitute for it. It's a whole talk by itself, but I just want to highlight that. And then finally, I just want to talk about the global oncology, the capacity building. So one of the things you can do with the comprehensive consent in the cloud or just online learning, like today, Project Echo, like we're using this platform for education, right? So I think this is the kind of thing that we should strategically support more. This is about research and doing this. So I think this is an excellent platform that we have today with this webinar, which is just amplify that. So, but I'll just point this out. So one of the things that was highlighted in the Lancet Oncology Commission, and that's beginning to really, it's really this award-winning collaborative education platform we call the Global Oncology University, where essentially you can do all these online classes, didactic components, like I'm giving this didactic lecture, but all the practical components can be done in a local site, like we're doing the clinical trials, right? So you can essentially train residents that way. But the cool thing here is, just like for the clinical trials, you ensure the quality of the education across all the sites. So you harmonize the education, and it will be the same quality of training that you get at Harvard, at Hopkins, or in Heidelberg, or in Oxford. It will be the same quality that you get in Lagos or in Kenya, in Nairobi. And so that can really be a powerful way to use technology to build capacity in research as well. And so this is really, so this is one of the countries that are already involved with this. You may have heard the IAEA is also looking at anchor centers. So in some ways, they're actually partnering with this initiative now, so that some of the anchor centers can really become like the local hubs for the practical training. So this is something that is really gathering investment. But I want to end with this. If you talk about research and you don't talk about money, then you're being a fool, right? There's no way you can do research without funding, right? So one thing that has been talked about, you may have heard about, is this idea of developing a global cancer fund. Right now, I can tell you it may not end up being called a global cancer fund, but it may be a global cancer financing platform, but it's coming, right? So actually the plans are, still, it was started with the previous U.S. administration, but now it's been transitioning to the private sector, really looking at, engaging people like Bloomberg and some other people. But I think also, people across Africa, to really be countries are really interested in this. And then the priorities will be, what should it fund? Eliminating cervical cancer is definitely top of the deal. Downstaging, but also innovation, like platforms like the C4 comprehensive, like creating that kind of innovation, futuristic thing that can really increase access to care. So this is something that, I actually will highlight that if you really want to support the creation of this, please contact us. Like, what I mean by this, we need voices to say, let's cancer is a crisis in Africa. Let's invest in it the same way that we invested in HIV/AIDS to that level or more. And people's voices matter. Like all of us on this course matter. Like to say this is important to you really matters. And I'll tell you that at ASCO this year, the conference in Chicago, over 50 organizations, the top professional societies came together and say this is important. But I actually feel like it's an elite thing. We need to have, grassroots people like you and I, fighting about this. So this is something that it's part of the strategy going forward to strengthen this. So I end by saying, I end by saying that this has to be a collaborative effort. All of us on this call, I think research collaboration is really critical. If you are thinking about doing a project, I think we should, with the network that we have, think about who you can reach out to help to work together. With the African saying that if you want to go fast, go alone. If you want to go far, you go together. It's really applicable in research. Just acknowledging funding, the Lancet Oncology Commissioners, some of them on this call, you did a wonderful work. I hope that, when we do the next commission or assessment, we can really, and we're already seeing a lot of the impact that this has had. But, I think this inspires us to do more research, to really innovate how we can address the cancer crisis across Africa. So I'll end by, just plugging this in. There's an event coming up in September at Harvard, online that you can join, in the Global Health Catalyst Summit. So we're really involved with that, actually supported the launch of this Lancet Oncology Commission. We're going to be talking about some of these comprehensive cancer center in the cloud implementation of it. So a lot of the theme will be about implementing it, but also a lot of research, innovative research that's happening in Africa will be highlighted. So if your time permits during this period, please, definitely take advantage of this or reach out if you have any questions. All right. Thanks so much.
Thank you very much, Prof. Will, for that wonderful, extensive presentation. I think we surely do need to clap for you for that, and also celebrate the work that you've been doing, including the Lancet Commissioners, and also at the same time, the collaboration and link between you and Dr. Simon Manga also goes a long way to have that way forward when it comes to cancer care. So you really highlighted very key and important issues, including financial constraints, and also at the same time looking at the ways forward, hopefully through the Global Cancer Fund. Yes, so do we have any, I think I did see a couple of questions for you on the chat box, but we'll give it maybe one more minute if we have any specific questions for you, Prof. Will, and of course, Dr. Manga, you'll be able to also answer some of these questions. If you would wish to raise your hand for questions, or I can also, of course, go directly to the chat box to get some of the answers. Okay, so I'll just go direct to some of these questions on the chat box. So first of all, Catherine Wambugu, is probably from Kenya. Thanks you for this amazing session and the presentation as well, which is very informative. And I know Pamela Were, a renowned oncology nurse who has been working in Kenya for many, many years when it comes to cancer care, did definitely mention the percentage of treatment abandonment, especially in Kenya, is very high. What are the possible causes of this? So that's probably a question that you can try and see if you can address. But also at the same time, one of the steering committees, Raphael Kibolo, basically says that it's very, very alarming indeed, though some improvements have been made. Yeah, so 54% is high. Do you have any comments about that? And of course,
Yeah.
Dora Machaki mentions financial challenges leading to the causes, especially with the current economy status.
Yeah. Yeah, Doris put her finger, assuming it's a she, on the button there, right there, because yeah, so financing is the big one. Even when we're doing these clinical trials that we've been doing across different countries, and Kenya is joined. Like one of the key things is that we see that consistently with patients, who have to travel repeatedly. I would say that's not even just a problem in Kenya, but even in the US, people also abandon treatment because you have to leave time from work and go. And the economic costs, so of that repeated back and forth travel, it's a big issue. And so one of the things the clinical trials we're doing is that we're cutting down the treatment time. So for radiotherapy, for example, for prostate cancer, you need to come in 35 times to get your first round of your treatment, so you can reduce those times from 35 today based on the science down to 5 or 6 or 7, right? So which means that instead of weeks and weeks and weeks of treatment, you can do that in, very quickly. And when you do that, you can get back, and that reduces the financial toll. So we've actually done some studies to calculate the cost that you can save by doing that. And it's significant, especially for families that don't have as much money. So financing is a big part. You may start the treatment, but usually they abandon it. That's because of that financial constraints. But in countries where universal health care actually is paid for, even the cost of travel is an issue. So we see that. But that's a really good question to actually take up to the, so we'll be meeting with the director of the National Cancer Institute of Kenya, to kind of see what some of the other factors are. But that's what we identified. The financing is one of them. The other one is, again, I kind of point that out repeatedly, is actually some of the cultural challenges. Some people have, just the limitations, in terms of, we've seen that with women who start the treatment, and then because of their men, we see what happens is that, the culture, they're dealing with it a lot in the society. And so sometimes you want to hide, you don't want to let people know about it. And, you try to find other ways to address it. So cultural factors also play a role. And then obviously access to the treatment itself is a big deal, right? So in Kisumu, for example, I can tell you, we're trying to help build a cancer center there in Kisumu. Right now, the people around that Great Lake region, they don't really have an access to a particular solution, right? So they have to travel to long distances to do it. And that's a financial problem as well. That access is an issue for them. So that's Kenya, but there are other countries face similar challenges, and so that high number definitely has to do with finances, access to care, cultural factors. To what level, or combinations, it's a good question to research on, but those are the factors.
Absolutely. So thank you very much, Prof, for that to address that question. I'll just mention a comment here before we get to Victor Moody's question. So Robert Marine, indeed, 1 out of 5 children surviving childhood cancer in sub-Saharan Africa is unacceptable. It's even worse when those who survive are subjected to stigma. So as you mentioned, advocacy is very crucial and important to address the stigma issues within the communities, 100%. But the question from Victor Moody, how has self-sampling contributed to enhancing sample representativeness, participant compliance, and the scalability of community-based cancer studies? Additionally, are there ongoing research initiatives or program developments focused on patient navigation and the role of patient navigators in improving cancer care outcomes?
Yeah, I mean, those are two loaded, and I would say 2 questions there in one. One with self-sampling, and I'm assuming that part of it is also related to statistical. So that's one of the things that, with the comprehensive cancer study in the cloud, actually, we've seen that a lot, that most people who conduct some of this research, they really need support in terms of doing some of those statistics. in the studies that they conduct, including clinical trials. And so, is that a is that a factor? I think that's a factor that has to be considered. And I think that we need to strengthen capacity, research capacity. We need to create access to either collaborators or to facilities that can help address that. The navigation question is really important, I would say. Patient navigation is a big deal. Like, first of all, when you get a diagnosis of your cancer treatment or, of diagnosis of cancer, you know all the emotions, all the challenges, all of the things that you have to go through, and then being able to navigate, where do I go? What's the next step? And then when I get a step, do this, and then what's next? Like, and we know for a breast cancer patient, for example, even the emotions that go through, first the denial, and then you start dealing with the treatment, the side effects of that treatment, plus then after you're done, even when you're done with your treatment, the navigation of palliative care or support, continuous support, is a big problem, because suddenly all those healthcare people around you have disappeared, and then you have to deal with things by yourself again. Navigating that is really tough. And we hope that even with the technology today, the technology platforms, like what I mentioned, that was just an example. There are many other platforms that have been piloted in Africa on patient navigation. I know here, a number of companies are actually doing that, helping to help patients to navigate. I think that's really powerful. If every person in Africa who has a mobile phone, if you could have something there that if they had to do a cancer, it can help them navigate them. Let's say their healthcare assistant, which I know that's where the future is going, just help them navigate their care. That would be powerful. So that's something that we need to really invest in the research around that, but also making sure that people can have access to that navigation.
Thank you very much, Prof. And as you clearly made it clear, when it comes to patient navigation in cancer care, that definitely does improve outcomes. And we've seen some countries who have been able to adopt patient navigators to be part of the care system.
Yeah. And I just want to add that actually that also helps with the abandonment, right? So if you can help people navigate their care, you can also actually probably reduce the rates of abandonment, so. Yeah.
All right. So we have Priska Gituka, who says, thanks for the great presentation. And of course, Rafael as well. Pius as well. Perfect presentation. It was insightful. Success, failures, complaints. Looking forward to learn more about cancers. And then Zipporah Ali, Dr. Zipporah Ali from Kenya. Thank you for the educative presentation. Yes, and Rafael did mention that he saw that the Kenyan abandonment rate is at 54%. What is the average rate in Africa, if you may know?
That's a great question. I don't have it offhand, but that's a good question. I know it fluctuates, from country to country and region to region, but yeah. I think I put 54 there in the Lancet. I have to go back and look at what was the report, but we put that there because that's one of the numbers where we're really surprised too, right? So putting that to just shock people to say, okay, this is not. And Kenya is probably one of the countries that actually has a better healthcare system than other countries. So, it just highlights the magnitude of the problem. But I don't have a ready-made number for you, like to say that in terms of the average.
And then Priska again basically says if it's possible to share the details for registering for the summit in September. That'd be great. And we'll share it on the WhatsApp group as well. You can share that to us on email or even here on the chat box so that they can access it. So
and I know you have my slides. So the slides are going to post it. It's in the last slide. Actually, I have the link for it. It's in that last slide, so you can just, if you have access to the notes. But yeah, I'm happy to also send that to you, so you can share. That'd be wonderful.
Yes, and indeed, at the IECO platform, the presentation is already on board, and it's on PDF. Anyone can access it. Access the link as well for registering for the summit in September. So all should be well and done, and of course, we'll provide the link for easy access. So we have a question here from Edward's possibility. So Edward is from Malawi, and thanks you for the presentation.
The first person between you and me was it.
Second. this person. Thank you. Right. So one question though. Do you think the imaging tools available now are a major contributor to an increase in cancer diagnosis?
What a powerful question. In some schools, I mean, like we've had that conversation, like, are we over diagnosing people? It's a good question. I think the imaging tools that we have today, I would not say they're a major contributor to the increase in cancer. I think if you're saying that if we have access to imaging, can we increase can that help increase the number of diagnoses of cancer? Yes, and hopefully you can catch the cancer early. So actually we just passed in the WHO World Health Organization resolution on increasing imaging capacity. That was actually led by Cameroon, who's on board of the directors, and then a number of countries, Brazil, and supported by other African countries. And the focus there is really kind of why imaging is really important to help downstage disease, making sure that people have access to it. All countries should invest in imaging. The current imaging tech tools today, CT, MRI, ultrasound, all of those things, they should invest in that because that's going to help catch the cancer early. And that can really drive some of the problems we have in Africa with the late diagnosis if people have access to that. So now the nuance that you want to point out there is that, sometimes, people have said, with imaging, if it's not safe, and I think that's a problem, especially for kids, that's a problem. In fact, that's something that we are gathering data in, I would say, Nigeria and South Africa right now, a number of countries where we think CT imaging and X-rays that we do are not safe in those countries. They don't have the right quality assurance for doing some of those things. The IAEA normally does the safety stuff, but if you don't have qualified and well-trained people to administer that, it's exposing, especially kids who still have a lifetime, they can develop secondary cancers from that, compared to adults. So that is a problem. I think that we need to make sure that if you have access to imaging, that imaging is safe. It is safe.
Fantastic. Thank you very much. I think I have a few comments here. As mentioned about patient navigation, again from Pamela Were, think of these. We need a strong wing of patient navigation right from grassroots. And she also mentioned about the percentage of treatment abandonment, especially in Kenya, is very high. What are the possible causes of this? Do you have any comments around that?
Or the percentage of treatment abandonment, especially in Kenya. That was what we discussed earlier on the financial, the cultural, the access and stuff like that, long distances and things like that. So, yeah, we did talk about that earlier. Yeah.
Okay. Right. So, great. Thank you very much. And it's actually just 30 minutes past the hour. So, do we have any questions? Any more comments for Prof. Will? All right. 1 second. I think I need some water. Just a second. Right. So I think we're all is in order. Yeah, I think this is in order. So there we go. Thank you, Prof, for your really, really insightful presentation. And I think it's a great opportunity to have that on board and also continue the conversation with the Lancet Oncology Commission. And of course, for Africa, it's a great way forward to have that conversation. And we also appreciate the efforts that you're making to ensure that there is a global conversation about Africa's cancer research and also controlling cancer within care spaces, and also that collaboration with other entities. So thank you very much, Will, and also Dr. Manga, for being with us. Of course, we appreciate your time and also appreciate the efforts that you have been able to be with us on this last session of the year. All right, so I'll just turn it over to a couple of people so that we can have some announcements and also some ways forward. But thank you very much for the claps. I think we can do some virtual clapping for Prof. Will and also Dr. Manga.
Thank you so much. Thank you. Have a great summer. Thanks. Yes.
Thank you, Prof. So
winter.
Yes.
Winter if you're in South Africa.
Absolutely. All right. So just a couple of people to speak. Just to let you know that, yes, indeed, this is the last session of the year. We'll be sharing a couple of things here for everybody just to be aware of the ways forward. So we have an evaluation survey that we'll be sharing to each and every one of us, who will be able to provide just some feedback to the program and the ways forward in terms of strengthening the community. And part of this survey is we have a section towards the end to have a call out for professionals who are willing to join in the steering committee of this particular ECHO program. This ECHO program has been on since 2018, 2019, and it's been led by a steering committee, volunteer, open committee to be able to run this particular program. And ideally, we have a call out every single year to have some steering committees join in, as some would probably want to be able to exit as they have been able to support the program. So there's a QR code here. And also at the same time, I'll be sharing a link at the chat box so that we may be able to have some feedback. So you can access all this at the IECO platform. It's as simple as about 22 questions. You may be able to provide some of your feedback. Take your time. It should take about 10 to 15 minutes to be able to share your feedback. So I know there's a couple of steering committee members with us. I know I've seen Raphael, I've seen Angela Mwanza, I've seen Dr. Kudus Lawal, and a couple of other steering committee members, including myself as vice chair, and also Professor Ntokozo Ndlovu as the chair of the steering committee for 2024-2025. I will give her an opportunity to speak, and then also have Phoebe Ongadi, the executive director of KENCO, which is the Kenya Network of Cancer Organizations, the primary hub for the Africa Cancer Research and Control ECHO program, which is also being supported by Project ECHO, have the last word of the day. Professor Ndlovu, if it's possible, you could just give a word towards this end of the year. Just some wonderful remarks from your end, and how it has been throughout this year, and what we foresee in the nearby future.
Thank you very much, Dr. Mbunya. First of all, I would really like to thank the speakers for today's session, Prof. Will Ngwa and Dr. Simon Manga, for actually just giving us a grand closure to the year through their amazing presentations, which were very informative and highly interactive. Thank you for accepting our invitation to be presenters for this session. And just looking back at this year, it's been marvelous, wonderful. We've had very good sessions, excellent attendance, and I believe that this will continue into the new 2025-2026 season. Thank you all for attending, and thank you for supporting this ECHO platform.
Thank you very much, Prof. Ndlovu, for also your leadership as the chair of this program. And we hope to have you again be chair for 2025, 2026. And also looking forward to seeing some of the feedback, looking out for a couple of other professionals who would wish to be part of the steering committee. So I'll hand over to the executive director of KENCO, Phoebe Ongadi, to just do a round of announcements and also a closing remark.
Thank you very much, Dr. Sam. I think you have said it all. I will not add much. Just to appreciate one more time the steering committee members. These are experts that are drawn across Africa, and they have been really the power and our wings, and I've seen that a very successful year. Though we have just one more session, Dr. Sam, don't be quick to go before the year ends. Yeah, so thank you, and Professor Gui, and also Dr. Manga, that was very, very appropriate for us. In Kenya, we are just coming from the National Cancer Institute Summit, and most of the things that were shared here around cancer financing, around early detections, around patient navigation. Indeed, it's like Africa are twins in most of these challenges. So we are hoping that even as we go with your commission and also with the outcome of the study that you're currently doing, that it will indeed inform some of these best practices in Africa. So one more time from our end, we will share the certificates. As Dr. Sam said, if you register via iEcho, you'll get it through your email. We're also going to share a copy of this recording. Please watch out. And thank you very much for your time. We appreciate you. On behalf of the KENCO Secretariat and on behalf of the Hub and also on behalf of the steering committee that's worked tirelessly, I think this is one of the best years that we have had. Thank you very much from the bottom of our hearts. See you in the next one.
Thank you very much, Phoebe, and not forgetting Mishka. I had mentioned her name being part of the steering committee, of course. Thank you all, and kwaheri in Swahili. Goodbye.
Bye, everybody.
Thank you, Mishka. Bye.
Goodbye, everybody.
Bye, Salome.
Ciao, everyone.
Bye,
Enjoy.
Bye, everyone. Bye.
Thank you, Angela.
Let me see my movie.